This adjunct is used as an alternative to an oral pharyngeal airway in patients who need basic airway management. Adjunct. This is what we call the nasopharyngeal airway. Other people call this nasal trumpet. It's a soft rubber or plastic handcuff tube that provides a conduit for airflow between the nares and the pharynx. So as all we know, oral pharyngeal airway, if your patient has active gag reflex or still coughing, then you cannot use oral pharyngeal airway and then you're substitute it with the nasopharyngeal airway. Other uses is that when your patient not only has a gag reflex but also has trismus, massive trauma around the mouth, or wiring of the jaws. NPA can also be used with a patient who are neurologically impaired with poor pharyngeal tone or coordination leading to upper airway obstruction. So before inserting the NPA or the nasopharyngeal airway, of course you have to look for the proper size. So you have to compare the outer circumference of the NPA with the inner aperture of the nares. The NPA should not be so large that it causes sustained blanching of the nostrils. In quick assessment, you can use the diameter of the patient's smallest finger as a guide to selecting the proper size. So what are you going to do is you're just going to pass it gently along the floor of the nasopharynx. And if you encounter resistance, you have to slightly rotate the tube to facilitate insertion at the angle of the nasal passage and nasopharynx. And attempt placement through the other nostril because patients have different size nasal passages. So as much as possible, when inserting a nasopharyngeal airway, try to insert it softly, not forcibly, because the airway can irritate the mucosa or lacerate adenoidal tissue and cause bleeding with possible aspiration of clots in the trachea. So what could happen if you improperly chose the wrong size of NPA? It may enter the esophagus. With active ventilation such as bag mask ventilation, the NPA may cause gastric inflation and possible hypoventilation. Okay, don't you know that an NPA may cause laryngospasm and vomiting, even though it is commonly tolerated by a semi-conscious patient? So you are holding the NPA and you are ready to insert it through the nose of your patient. And what must you really have to remember? Make sure that your patient has no facial trauma. Why? Because of the risk of misplacement into the cranial cavity through a fractured cribriform plate. So after insertion of either an OPA or an NPA, what should you always check? You should always check for spontaneous respirations immediately. And what if respirations are absent or inadequate? What do you have to start? You have to start positive pressure ventilations at once with an appropriate device. Let's say if adjuncts are unavailable, you have to use mouth to mask barrier device ventilation.